And what we can see in connecting to cloud server, I hope everybody can hear properly. There is a lot of yes, perfect. A lot of messages are popping up.
Yeah.
So we can see within adolescents a very wide range of physical development, intellectual development, social interactions, and emotional changes that happen during this period. So it's a time of accelerated development and change, during which the adolescent is transitioning from childhood to adulthood, and that goes through a number of phases to which palliative care services have to adapt, because these are not easy transitions. So children and adults, meaning we cannot say that, adolescents are a specialized group. They neither belong to the children's palliative care, we could say, nor to the adult palliative care. But even so, usually for the time being, it is pediatric palliative care services which attend to the needs of teenagers. So which type of life-limiting conditions do we see in adolescents? As you have already seen in the first class about pediatric palliative care, we have those 4 classifications of conditions, starting with life-threatening conditions, which may sometimes be reversible, may get cured, but there is also a risk that it doesn't, such as cancer, traumatic injuries, resistant tuberculosis, or HIV. Then we have life-threatening, non-reversible conditions. Many of our teenagers may be suffering from stage 5 chronic kidney disease beyond hemodialysis, or peritoneal dialysis, cystic fibrosis, and so on. Long-term illnesses, long-term conditions with increasing disability, maybe DMD, cystic fibrosis. So there is a steady decline in the health of the teenager until death. And long-term conditions which are stable with good care, but which have very specific and usually complex needs, such as cerebral palsy. So the usual developmental milestones during adolescence are challenged by life-limiting illnesses. Puberty and intellectual development may be delayed. And there is usually, during that development of cognitive abilities, higher and maturing abilities, abstract reasoning, this might be really disturbed by the diagnosis or the continuation from childhood of life-limiting illnesses. Teenagers have an emerging sense of identity, including body image, which may be gravely damaged by the illness itself or by the treatment that the child is undergoing. Increasing desire to function independently from the parents contrasts with the increasing dependence from the parents because of progressive illness in many cases. And there is also an increasing importance of intimacy with peers, which actually those relationships cannot be maintained so easily when the child is going in and out of the pediatrician's clinic or the hospital for treatment, or stays longer periods of time admitted in the hospital. So we'll start with a case of a 13-year-old girl who had fallen from a swing, which actually led to the diagnosis of C1, C2 subluxation, which was congenital, but as a consequence of the fall, she became quadriparetic. Neurosurgery, surgical intervention could not really fix the damage that was already there, the neurological damage. She was ventilator dependent when she was referred to us 6 months down the lane, had multiple shifting from the ICU to the ward, and there was real difficulty winning off the ventilator. She had already been, I'm in hospital for actually a year, 6 months to 1 year. So the palliative care team intervened, and we looked at the physical as well as psychosocial and spiritual issues which she and her family were facing. She was the eldest of 5 siblings, and her father was a daily wager from Mumbai. Physical issues were, of course, loss of mobility. She was bedridden with a lot of nursing issues. She was dependent on the ventilator. But she was tracheostomized, and she was able to be fed. She was conscious oriented and able to speak also. Emotional issues, there was a lot of girl and mother difficult relationships. The mother was often burnt out because of being the only caretaker in the hospital. Anger and oscillation between hope and sadness, mostly on the part of the mother and the father. And socially, she had been separated from her siblings for many months, couldn't interact with her peers, wasn't obviously not going to school, and her mom was in the hospital 24/7, and there was a lot of financial issues for which we had to help them out. Spiritual issues, the usual why, and thoughts such as God has been unkind to us. We are facing poverty, and above this, an illness which is bringing us down. So after assessing the issues, we need to address those issues. I'll let you think a little bit about the nursing issues you would think of. So there are issues related to being bedridden. So prevention of bed sores, positioning, airbed, issues related to the tracheostomy and ventilator, so suctioning. The mother had to be properly taught. So the whole bedside teaching by our nurses is to empower the parents to ensure proper care in the hospital, and thinking of maybe future plan of home care. Then, of course, oral care, nutrition was also an issue. She was lack of activity, so she was putting on weight. Yeah. And then what is the role that a palliative care physician has in the interdisciplinary palliative care team? That is mostly eliciting the goals of care from the parents. What are their hopes, their doubts, their fears? And we needed to bring their hopes down to realistic hopes, because they were hoping she would walk. They were hoping of course, she would be weaned off from the ventilator. So that was a hope we could maintain. But telling them that she would not be able to walk, they were hoping to take her home. Initially, it was out of the question, because as soon as the hospital took care of all the finances, and she was 100% covered by the social service department, then they realized that it was obviously much cheaper to stay in the hospital. And then coordination of care is important in planning the interdisciplinary team meetings with the pediatric ICU, neurosurgery, ENT department, physiotherapy, occupational therapy, and so on. And then we assessed what are the psychosocial issues for which we visited her every day to cheer her up, let her talk, organize diversional activities, as well as educational activities with a volunteer teacher, teaching her English, maths, that could provide some time off for the mom to go out, to rest, and proactively encouraging occupational and physiotherapy. And reassessing again and again ventilator dependence. Because there was a mixture of both physical and psychological dependence. So it was a very slow and gradual weaning, which we managed to do over a course of 6 months. We started using a wheelchair with a portable ventilator so that the mom could move her around the hospital and take her to our playroom. And we managed to get her 4 siblings over for Raksha Bandhan, despite the rules of the hospital that don't allow children who are not sick children. So I will hand over to Anu.
Thank you, Vero. Yeah, so the case of Poonam brought in so many memories of the months that we put in along with this girl and the family, how she was so interested in wanting to talk to us in English. So, you know, whenever we would go, we would encourage her to talk in English, give her worksheets so that she could solve some maths, sums. So, you know, it was like how the entire team, so nursing staff would go and take care of her nursing things, and we had volunteers who would come. In fact, we also had Holi, so she loved water and color. Uh, so we couldn't take her out in the rains, but color we could help her, and we have a lovely photo of her with, you know, color on her forehead on Holi. Yeah. So when we're talking about adolescents, we need to understand illness and being an adolescent. Just because a child and an adolescent, a young adolescent, has a life-limiting condition, he still remains an adolescent. So we can't, you know, move both of these separately. Okay, let's just look at the illness and not think about the adolescent. So there are some normal needs that every adolescent would have, and so would this child, despite being in the hospital setup or being sick for a continuous period of time. And they would have the same mood swings, the same expectations that any other adolescent would want. But we need to be, you know, cautious. You need to be able to differentiate the behavior that is linked to normal adolescence and something that is caused by a medical condition. Next slide, please.
Can you please mute yourself?
Mute yourself. Somebody is unmuted.
Dr. Nitin, please. Dr. Nitin Manwani, kindly mute yourself.
Okay, I will continue.
Maybe Vinila can mute him.
Vinila, or even you can. Veronic, even you can mute.
I can.
Yeah.
Okay.
Okay.
But to do that, I have to, sorry, I did something. Stop share.
Yeah. So,
sorry.
Let's try to understand. We're trying to look at what an adolescent would usually, I don't know, the word normal sounds, then we have a connotation of normal and abnormal, but what a usual adolescent would be, and an adolescent with a life-limiting condition. So a usual adolescent would like to be along with friends, go out, you know, do things that he would like to with on his own. But an adolescent with life-limiting conditions, we see that, you know, most of the times is isolated, because most of the times either he is in the hospital setup or in and out of hospitals, in and out of the hospital because of the medical condition. An adolescent usually would like to be with his or her friends, you know, maybe play together, go out for movies, study together, go to school or come back together. But here, the adolescent who has a life-limiting condition, he feels different because he can't do all this another normal, another child his age would be doing. An adolescent usually wants to be a part of a group. And I think adolescents thrive on this group behavior. But with an adolescent who has a life-limiting condition, we see that, you know, his disabilities prevent him from full participation. Sometimes it's probable that he may be able to speak to his friends, or friends may just drop in once in a while, or one of the few friends would just come in. But it is not just going to be equal to what another adolescent his age would be doing outside the hospital setup. An adolescent is very, very obsessed, you can say, with his physical appearance, and continuously wants to improve, wants to see what's the latest that everybody puts in, how he looks. But here, an adolescent with a life-limiting condition, we see the appearance is changing, but surely it's not changing for the better. So sometimes it's the skin is losing glow, they must be losing hair, they must be losing weight, they must be using some crutches to walk, or be on a wheelchair, not be able to move around. So the appearance is changing for an adolescent with life-limiting condition, but most of the times it's not for the better. If they have some bandages on them, they're not able to, every day bathing and cleaning themselves also becomes difficult. Usually an adolescent would want to be increasingly independent, would want to do things on his own, decide things on his own. But an adolescent with life-limiting conditions, we see, is increasingly becoming dependent, even for minor things. He wants a glass of water, somebody around him should be giving it. He wants to go to the washroom, it's his caregiver who's helping him with a pot, or helping him with the diaper. Or so all these things are happening with an adolescent who is with a life-limiting condition. Usually decisions around everyday activities, it could be like what clothes I will wear, to where I will go, to when I will wake up, to when I will do this, or when I will study, or when I will play. All these decisions are usually made by adolescents on their own. And we know that it's a major reason for clash with the parents. But when an adolescent is in a life-limiting condition, we see all these decisions around his health options and dying are not majorly not even made by him. But the decisions are not about what clothes I'll wear and where I'll go and what I'll eat, but it is about what needs to be done because of my condition. What should I eat? What should I not eat? How should I be going? Or also it could be around dying. We're not even talking probably of living there. An adolescent, we see he's developing to be an adult. His role in society, his role in the family is increasing. His opinions matter. But with a life-limiting condition, he's increasingly dependent. Another adult or even another sibling is probably taking care of this child here and of his basic needs. So it could be like, even to play a game of snakes and ladders, the dice may be thrown by his younger sibling, and the child is playing, just being participating over there. There are changes that are happening with adolescents. Usually there are changes in the body, there are changes in the emotions, the way they deal with the environment. But with a life-limiting situation, the adolescent is also dealing with body and emotions, but mostly it is towards illness and emotions around this. Emotions could be of sadness, guilt, at times anger, all these coming up because of these life-limiting illness conditions. There is a high desire of independence and privacy, which we see if an adolescent is in a life-limiting condition. Privacy is at most of the times hampered. The child is not sometimes fully dressed, just needs to be covered with a blanket. Sometimes if he needs to pass urine or stools, he cannot do it as he would have done it had he been healthy and normal. Sometimes there are no curtains around, and they have to just deal with all these changes that are happening in them. Adolescents usually would want to enjoy life, have a good time, laugh and joke about things. even children or adolescents with life-limiting conditions also have the same, wish, but most of the time they're hampered and uh, they're not able to fulfill those wishes. That's where probably our team comes in the picture, and we try to see how close to those wishes we can manage to go. So what are the aims of palliative care for adolescents? As we said, it's a very special group. These are not children and these are not adults. So this special group we need to be taking care of cannot be like a routine like we do it for everyone. It has to be customized. So the first aim would be to relieve the suffering that the adolescent is going through and have an improved quality of life. So whatever the quality of life at present, see how we can improve that quality. So if the child is just lying in bed, see how we can do something in that situation. If the child is able to sit in the bed, or he is able to sit in a wheelchair, or he is able to walk, depending on all these situations, we see how we can improve the quality of life to the next level. Go a step ahead, go a step ahead. Like I just shared about, sometimes children who have muscular problems are not even able to shake a dice and uh, while playing snakes and ladders. We say, okay, fine, no worries. Put the dice in their hand. Let them just drop it and somebody else moves the coins for them. But at least they are involved. So we try to see how we can improve the quality of life from the present level, depending on the condition of the adolescent, helping them to live as well as possible for a long time. We need to make sure, I mean, what we're trying to drive home here is illness is a part of this adolescent's life, this child's life, but it is not the entire life. So taking care of the illness is something we do, but there are other aspects to him, other parts to this child, and let's see how we can help them live as well as possible and as long as possible, so that we're taking care of the medical issues and situations also. How to adapt to changes. This illness has brought in a lot of changes in the life of an adolescent, from being, getting up every day, packing his bag and going to school, going for tuitions, playing, hanging out with friends, being a part of a school or a college sports. All this has suddenly changed when the disease has set in, either has set in now or has been through since childhood. But the changes from inside, as to, okay, now I cannot get up and walk, but what can I do? And changes even outside. Uh, Another aim that we, for our adolescents, is to support progressive autonomy. How we can reduce this dependence, how we can make them feel okay, because that's something basic to an adolescent. He would want to be autonomous and want to do things on his own, and see how we can support in this context. Also maintaining the social context for an adolescent, that social connect is so important, and see if we can maintain that. In our hospital, if a child is in the hospital during one of his birthdays, we see to it that he doesn't miss this day, and we celebrate birthdays in the ward, even in the ICU if required, take some special permissions, take special care as to what we are doing, and see that a child feels happy even during that day, which otherwise, had he not been in a hospital and had he not had this condition, he would still be celebrating it with his friends. So we try to see as much as we can do. Maintaining hope, because what the child hoped for before has now changed. So maintain that hope, and supporting the parents and other family members and caregivers, be it siblings, be it close relatives who are involved with this child. This is another major part, because the child is not single and alone who we need to take care of. He is connected to all these people in his life. The way they respond and they react to his situation, his condition, all this affects the child also. And also support them in dealing with ongoing losses. there is a lot of loss. There is loss of mobility, there is loss of expression, there's loss of normalcy. There are so many things that the child is losing, and we see that we can do. But what is the key aspect? Than compared to any other age group, communication with this age group is key. If you can communicate with them well, you've kind of hit it. You have to know their language, the way they talk, the way they walk. Otherwise, there's always a distance that remains between them and you. So a few of these photos will tell you how, irrespective of age, we are all there along with them. We see that friends form a big integral part of an adolescent's life. Even in the hospital, it's like form a mini world here where we can give them glimpses of the world that would be outside, that they are kind of missing. Give it to them here. So peer support groups, children of the same age group get together, let them play, let them talk, let them share experiences, let them support each other also throughout the treatment. And of course, it is done under professional guidance, under our guidance in our department. Uh, it is important to give them time, give them the respect that they would, not treat them like, oh, your opinion doesn't matter, just follow what we say. Doesn't work with an adolescent, because they know they have questions, they have opinions, and it's best to respect them, give them the time and the presence, acknowledge that yes, you are important, allow them to question. You can, you would be amazed to the thought process of an adolescent, the way they have questions, the thoughts that go in their mind. And if you allow them to come out, it gives us an understanding of what's going on in their mind. We're able to work with them better. We are able to deal with the issues they are going through in a better way. If we do not, then it's like two different worlds. We are together, but we're not able to connect. So this communication is the key. You can see a few pictures here of kids coming. This is our department where they're playing carom. All the kids are similar age. There was these three children you can see on the seashore, relatively same age, and they bonded so well in the hospital. They formed such lovely friendships. The hands you cannot see, but each of them have a friendship band in their hands when they went out. And they wanted to see the seashore. So with the help of our team, we went together with them, took care of how they travel, took care of all their medical needs, and took them out on a seashore, took them out to eat what they could eat, of course, with all the restrictions that they were supposed to be following. And they had a blast of a day, and memories for us and for them. Unfortunately,
And
yes, Vero.
I will add, actually, they all had the same relapse leukemia, the same condition, relapse leukemia, during which the three of them shared really their had a lot in common, and one of them did poorly, and we ultimately lost him. But that's when the other two, so we fulfilled this wish of his with the other two, which after his, when he was already quite sick on home care, the other two wrote along with many people who looked after them on a huge card, which we made with photos, with messages, and our team members, two of our team members, went to their house, a village 2 hours away from Panvel, which was really the other side of Mumbai.
To access, yeah.
Mm.
Yeah, so
Yes.
this this budding friendship, which would have happened anywhere else outside a hospital setup, happened right here, along with the treatment and along with all the limitations that we all had to deal with. They also had to deal with, and so did we. We also celebrate birthdays, like you can see in the photograph. And it just makes their day special. Just because they're in the hospital, it doesn't mean that they do not celebrate that special day. and we just go an extra inch to see that that is done. And they enjoy sharing a small piece of cake with their neighboring friends who are in the same ward, and they become their peers.
Sorry, I have a problem in the going to the
No,
next.
yeah.
Yeah, these are children with CKD who are in a peer support group, and also support group for the parents of children with the same condition is very powerful.
Yes. Most of the times parents feel that, feeling of doom coming over them, our whole family is suffering, our child is suffering, there is so much of problems. But when they share and talk to each other, they actually support each other through that journey. When they meet in the hospital, sometimes even when they go back to hospital, they go back home, or they're no more in the hospital, they connect with each other. Another important aspect in an adolescent child's life is social media. Nowadays, we don't see a single child in the hospital, in the ward, not a younger child, not an adolescent without the phone. He'll use the phone for n number of reasons. Um, he will also use it to find out what his diagnosis means, what did the doctor say, what did the file say. But it also helps them keep in touch with friends who they're not seeing anymore, probably their relatives, family members. So it is, we do encourage them to, make video calls to family members, to siblings, to friends who they've not seen for some time. It just helps them keep in touch, and just know what's happening. Sometimes just check on the sibling who's in 10th standard and see if they're studying or no. This makes them feel that along with being sick and along with all the treatment, we are also able to be a brother, we are able to be a friend, we are able to be a son, etc., etc. It also offering help for others sometimes, and finding meaning for themselves. So social media is something kind of helps them. We've had such lovely, you can say, the reels that we see, the selfies that they take, the photographs they make, the videos that they make. It's just, even in those situations, you'll see the background is a hospital, but there are videos being made of them, and they're sharing it with their friends, sometimes with family members. They're also sharing their experiences, and they're telling their stories through these. Social media is something that's helping them do that. So even the child who was in the hospital for a year, the mother and the daughter would take selfies, add songs and music to those selfies, and send it to family and friends. And it used to be with the same background of the hospital window, or other beds in the hospital. But that is something that they would do, and that was their reality for them, for that time. And they would tell their stories using social media. So Instagram and God knows reels and what not would be used here. Of course, we need to be careful, have a balance between what we are sharing, and also be careful as to we're not exposing them to any abuse, but also to support them. Of course, through usage of social media, sometimes when we look at statuses that these children put up, or photographs that they have put on the DP, or shared, gives us an idea of what's going on in their mind. Sometimes children would want, when they become more unwell, they're more sick, they're in the hospital, they're not feeling too good, they would write, please mute yourself, Hareen Chintapalli. So sometimes they would want to cut off, we've had situations where children who've lost their hair, or the skin has become very dark and it's not looking too good, and they're not looking their best. They would not want to talk to people on video calls. They would just rather just make simple calls. So we also make use of social media with all its plus points to help children who are in the hospital. Where we would talk about.
another case of a 17-year-old girl who was diagnosed with an Ewing sarcoma of the femur at the age of 10, completed chemotherapy, had a rotation plastic surgery, so a little bit disfiguring. In 2017, she completed everything, and she was referred to us when she relapsed in August last month. She had swelling in the femur, she had breathing difficulty, and there was a huge landmass which you can see eroding the rib, and the biopsy confirmed that it was a relapsed metastatic Ewing sarcoma. So then the joint counseling is usually happens between the pediatric oncology team and the palliative team, along with the teenager and her mother. The father was not in the picture because he had abandoned the mother. So Anu was the one who went for the discussion of the prognosis.
Yeah. So when we were aware that this is a for sure relapse, and we had to disclose the prognosis to the parents. So it was, the first discussion was, let's have it with the mother first and then maybe talk to this girl. But from the time we have seen her, we always saw her as an independent, somebody who was opinionated, who knew, came from a very low socioeconomic background. Mother was the only one who was, she used to sell garlands on the roadside, on the signals in Mumbai. And she would hardly make some money for them to just sustain. She had an older sister who used to come with her when she was previously admitted, but then now she was pregnant and she was due for delivery. So the older sister was in hometown. So it was just she and her mother. And we felt, knowing what this girl is, let's not keep it from her, and let's also make her a part of the discussion. And she too was called in along with her mother and her cousin brother who was there. And she was told about the recent test reports. Initially, yes, of course, a tear did come down from her eye, and she felt, okay, so it's come back. Now, what do we do? Is there a surgery possible? Would there be more treatment? What would be the treatment if it is so? Would it be very difficult? And I think she just took around 2 minutes for her to collect herself. And it was not her mother who was asking all these questions, but it was she herself. And she also had the capacity to say, okay, if chemo is, during chemo, if this illness has come back, then what is the use? Should we be continuing with little more chemo again? And so somebody who could reason out, she did feel sad, but she asked about all that could be done, could not be done, and what would happen. The next day when I went and spoke to her and asked her, how was yesterday? She said, today I'm fine. Yesterday evening was a little difficult. And I was wondering, why did this happen? And I was hoping it would get better, but it's fine. And she was back to the same tone that we've been knowing her for so long. So when we're discussing prognosis, we're looking at maintaining hope that could be possible. Of course, we are very realistic. We don't want to tell them everything is going to be fine and you don't need to be worried. We would always want to give a clear picture, but depending on how much and how, because most of the times in our conditions, we see it's the parents who say, I don't want my child to know about her disease, about her prognosis, etc. So it becomes very difficult. So we have to start working with the parents, tell them how our experiences with adolescents have been, how we found out that, it is around 99% of the time an adolescent knows what is the treatment, what is the diagnosis, what probable prognosis. But it's like a game that both are playing. Parents are playing, I don't know, in front of a child, and the child is playing, I don't know, in front of the parent. And we encourage parents to have open communication. But as a rule, we respect an adolescent and their wishes. So when we checked with this child, like, are you okay with us telling you about whatever further we will do and whatever the results are? She said, please, you need to tell me, don't keep it away from me. And that is something I feel is, that's going to help us deal with her right now, and probably even when she comes end of life, which is going to be very helpful. So in general, adolescents would want to be kept informed. It is so opposite the prevalent view that they don't understand. We are best to take care of what they need, and we know what they want best, and we will take the decision accordingly. But whether they want to continue treatment, don't want to continue treatment, whatever would they want to do, I think most of the times in general, adolescents would love to be treated as an individual, respect their individuality and keep them informed. Um, Agreement on goals of care is also important. So what does the adolescent feel about the goal of care? Whether he wants to be treated fully, whether he wants to know what the outcome would be, whether he doesn't want to go in for treatment, and respect that. It's not that you ask them and then still do what I would want to do otherwise also. So that, of course, goes without saying, but most of the times we as parents say, okay, fine, you don't want to do it, but I'm here and I want to go ahead and do it. Advanced care of planning also needs to be, so we plan for the worst, but also hope for the best, which we continue till the very end comes in. One issue that we look at and we encounter mostly with adolescents is compliance. Compliance to treatment is something that we see, because if you look at, usually an adolescent would be a non-compliant. If you say, don't go there, I would love to go there. Don't do this, I would love to do this and see. So we look at, so this is the same adolescent who's now come in with a life-limiting illness, but the core is going to be the same. So they're frequently non-adherent than adults in chronic conditions. So you will see that in conditions like diabetes or chronic renal disease, we see kidney disease, we see that, adherence becomes a difficulty with them. Okay. We need to see that motivation, collaborate, be mindful, use all their cognitive capacities, be flexible, and actively participate in the treatment. These are all good indicators of compliance. If these are missing, we see that compliance comes down. The effect of appearance, how they're looking, and also fear of that I'm different from people of my age group can also be a factor in compliance.
So I will not go into detail into this case, which was another example of a bone tumor in a girl who had severe physical symptoms, severe pain when she was diagnosed, and we treated her with oral morphine for early and rescue doses. She needed treatment for after each cycle. She had severe mucositis, but with this early palliative care intervention, she was a girl who was amazing, a very resilient girl. Our interventions, psychosocial interventions, including solving interpersonal issues between her and her mother, sorting out answering her questions about the surgery. So we helped her surgery that was going to happen after several cycles of chemotherapy. So we encourage her to write down all the questions that she will ask the orthopedic oncosurgeon when she would have the consultation with him, so that everything was prepared at least a month in advance. Body image issues. She was able to meet other cancer survivors, and all the relationships with her peers were like she continued her schooling online, because she was lucky enough that this happened during the lockdown. So as much as possible, she attended her 10th standard exams. She took her classes, sorry, and she took her board exams. And we addressed her mother's fear of relapse, which fortunately this girl is doing very well. She's now cured. And she was involved in a group therapy with support group of girls of similar ages. We always find that it's very powerful at that age group. Teens, we take boys together, we take girls together with similar diagnosis, similar treatment going on, and similar issues, and they can really support each other. Now she is often called upon whenever she comes to the OPD for her survivorship consultations. She's invited to go to the ward to talk to newly diagnosed children with newly diagnosed cancer, especially teenagers, sorry. And she is of a great support. And another issue I know is body image.
So
with another teenager here.
So so allowing choices of what they want to wear, how they want to look, this is so important. So we have this child here in the photograph who is, Pero, can you help me with the medical part of her?
She has MMC. Yes. She has MMC, and so she's totally paralyzed waist down, and had also urinary issues and bladder and urine issues.
Yeah.
So she moves around in a wheelchair in the hospital and on the floor at home.
So here, importance of cleanliness was something that we worked on, because initially when we were first referred, there was such a lot of odor, and we had to work on that, so that the odor comes less. She used to love dressing up, combing her hair well. She wouldn't like to just sit there because she's in the hospital and nobody is going to look at her. She would want her hair in place, wear good clothing, wear good earrings, color her nails. She's something, she loved to use makeup, but not much on herself. But our clown therapist who would come, she would come and help her with the makeup, and as much as possible maintaining independent activities that she would have done otherwise if she would have been at home. Even the nurses in the ward would compliment when she would actually go back with nice combed hair and new earrings, back to the ward after coming back to the department. Next slide, please.
And now I get issues. People keep on being admitted, and
encouraging them to express themselves as adolescents is something that has been very powerful. It could be writing poetries, writing a diary, writing letters to self or to somebody else, music, dance, art, crafts, or any creative. So the previous photo that you saw, the flower was made by the child herself. This was a flower, and she was so happy to show people that she made it. Storytelling, therapeutic play, all these are used as tools to allow an adolescent to express. Another important factor that with adolescents we look at is spirituality. A lot of spiritual questions, spiritual crisis, or existential loss. These are major themes in an adolescent when they're going through life-limiting diseases. So it is for the adolescent themselves, and also for the family who's there. There could be feelings of anger towards the parents, especially when the condition is like a genetic condition that they have acquired at birth. Could be like, I got it because of you, and otherwise I wouldn't have been going through all this. There could be feelings of anger towards the parents, which are addressed by our team. There could be feelings of guilt, especially in relation to parents. They feel their parents are going through all these troubles or all these issues because of them, their financial issues, social issues, physical issues. So when we're talking about spirituality, we're talking about finding meaning and purpose. And especially when we're dealing with adolescents, we try to see what is giving their life meaning. What do they wish for their life? What are their wishes? And as a team, we try to help them achieve this during their stay in hospital. So strengthen their connectedness to themselves. First, connect to themselves, their body image, help them develop skills that they will deal with the new normal that they're going through, express creatively, their relationship to others, their connectedness to others, could be their relationships, their peers, their classmates, their schoolmates, the new relationships that they also form in the hospital, the bond that they have with their parents. There have been so many situations where we saw there have been a strange relationship between the parents and the children, and this illness has brought a bond between them. Their connectedness to nature. So sometimes we take them out, bring them closer to nature. We encourage them if they go back home on home care, or they're discharged in between. Even visit a garden close by. One of our adolescents loved fishes, and she wished to go to the aquarium to see how an aquarium is. And we did try to work this out, have arranged everything, but unfortunately we couldn't convert it into a reality because she very suddenly passed away. But we allowed them to spend. So even around our hospital, we have trees, and we encourage them to face the window, see squirrels sometimes, see the trees after the rains, and connect with nature despite being in an hospital setup and in a life-limiting condition. Also connect to God. So spiritually listen to songs, pray, all that they would do in any other situation where they would face with crisis and trouble. Encourage them as to whichever faith they belong to. Follow that and participate. They need sometimes we have parents who would love to borrow the Bible that we have in our department, or they would like to read some religious book that would help them cope with this situation.
And the boy we have here, no,
Yeah.
this is Raksha Bandhan. You wanted.
So the HEMAT children had prepared Rakhis in the hospital, and our team gifted one Rakhi to him. So he was very eager to show that I have tied the Rakhi that you sent me, along with the two that his own sisters tied for him.
So in adolescence, as Anu already mentioned, we have specific issues, legal and ethical, when there is conflict over informed consent, and autonomy. So parents often wish to take a decision without informing their child, teenager, out of love. It's a desire for protection, and on their side, the adolescent wants to take an autonomous decision. So we know that adolescents until the age of 18, legally they cannot make decision, and the parents are the ones making decisions. When they can legally make their own decision, that may be also be in conflict with the wishes of their parents, those who are 18, 19. So all these are difficult issues for which a lot of communication is needed. And there are times when the adolescent also wishes to discontinue or not to begin certain treatments. And then we need to help parents understand the reasons for that decision and agree to that. We had a case at the end of life for whom blood transfusions were, it's always a gray zone whether to give or not to give. By giving, you increase the lifespan, but you also prolong the suffering. And that teenager who needed platelet transfusion said, I don't want any more pricks. He had edema, all his extremities were edematous. And he said, I know the consequences of my not getting platelets in this with thrombocytopenia, and the parents respected it. And then his last wishes were also fulfilled, and he died 2 days later at home. So I have taken these slides from a workshop, international workshop that has just happened 2 days ago in St. Louis in Memphis, that is in the US. And it's difficult to summarize in 2 slides only the ethical issues that can happen. But disclosure to a teenager depends on some factors which would increase that need for disclosure. The more mature the child is, and the older the teenager, the seriousness of the medical condition, and maybe a difficult treatment or a burdensome treatment, or maybe poor prognosis and reaching closer to the end of life. The impact of the condition on subsequent life decisions and opportunities, and the parents' level of inquisitiveness. So the patient, sorry. So the child, a teenager who keeps on asking and saying, please tell me what's going on. There is a genuine desire and right for the teenager to know it, and keeping the teenager in the dark is actually increasing emotional suffering, spiritual suffering, and when there is conflict. So this article really responds a lot to, it's very nice. There are all the responses to parental requests to non-disclosure to the children. There may be instances in which the medical team is ethically obligated to share diagnosis and prognosis with the patient. We are talking about pediatric patients, despite the parents' request for non-disclosure. In such an instance, pediatricians should reframe the discussion from whether information should be shared with the patient to how it will be communicated. So at times, we are a bit afraid to tackle these situations, because parents most of the time are going to say, no, don't tell him, don't tell her. But so the question is not whether you would like us to tell your child, but how are we going to tell him or her? Because they want to know, because they should know what they are facing. No, this particular child is going to undergo a liver transplant, and doesn't know even what is happening. And it's not a child, it's a teenager, because the parents want to do all the workup and then only tell about the chronic liver disease. And the child keeps on asking, when are we going home? And it's not fair. So it's very much the way we present it. And in the case of, as we said, teenagers are not big children, and they are not young adults. They are in a time of transition, and transition to adult palliative care for those who have chronic illnesses. There is a need for a time of preparation for that transition. It may begin early, and we need to explain, to involve the family. It's quite difficult when we have, for example, this girl with MMC is now more than 18. She can't come back to our pediatric hospital. So we are guiding her on the phone. We keep on going for home visits, but she now belongs to an adult. She goes to another hospital. It's very tough. They may feel unsafe because they lose the link with the team that they have known for so long. So it needs to be something that we are very, very new to this concept in India, but we need to introduce the adult team. No, we are going to shift from pediatric nephrology to adult nephrology. It may be across the road, but it's a different hospital. Can we have a social worker who goes and takes them to the OPD and starts explaining to them that this is the doctor who is going to look after you once you turn 18? And collaboration between pediatric and adult services should be, if possible, a progressive thing with shared decision making. And we may need to educate the adult team on the needs of a teenager, on certain conditions which are pediatric conditions which they are not familiar with in their adult setting, and about the treatment. So this transition, which is quasi-inexistent, needs to continue. And the role of the private practitioners, pediatricians, who keep on following their children and families over so many years, because you are not limited to any age restriction, is a very, very important role in that sense, to provide that safe environment and that continuity of care. So when we reach the end of life, it is a very challenging situation where a skilled multidisciplinary team, which includes not only healthcare professionals, but also the adolescent and the family at the center of that team, because they are the ones guiding us as to what are their wishes, their hopes. And communication is all the more necessary and crucial at that stage in the illness of the child. But there may be barriers which are both inherent to the child psychology and also external barriers which make communication more difficult. At that time, it's more common for parents to also feel that the child shouldn't know that they are reaching the end of life. But I think Anu can comment on that. All the children know. We had that big teenager at 16 years old with SLE and multi-system involvement, especially kidneys. And the day she was shifted for the at least second or third time of that final admission, she was shifted to the PICU. She told our book and toy librarian, who was the closest to her, pray for me, I am not going to come out of the ICU. She knew she was going to die. And I have to say that we feared that, but we were not sure. We felt it's another down in her condition, but she died in the ICU. So children, teenagers know, and that at that time they need an possibility of open conversations about what's going to happen, what they are afraid of, and what are their future hopes and their dreams. And for the parents, their hopes and dreams also die with their son or their daughter. So dream of a career, traveling, seeing the world, their relationships, seeing so-and-so family members or friends are all aspects which are very important when we are planning the end of life. Whom would they like to meet? Where would they like to be? Do they want to go back to the village and see their grandparents? Hopes of the parents for the marriage of that child. So it's a very complex situation at the end of life. And Anu will continue.
So, of course, still the adolescent is with us. Our focus, along with the parents, is still majorly on the adolescent, but bereavement support is something that we always follow up on, because the family, it's very difficult to lose an adolescent child. Their dreams, their hopes are destroyed. Their normal life cycle has been disrupted. For the last n number of months and years, they have been in and out of hospitals, following up tests, everything. And so the whole world revolved around this child who was unwell and who was sick. And the normal cycle had been disrupted. So other siblings are neglected, normal work is neglected. And now they've come back to a standstill where they say, I don't think there's any work for me now. Support in the future that has been taken away. There must have been so many dreams. I want my son to do this. I wish to see my son married, wish to see him, follow this career, etc. And the grief and the loss that they go through would be so intense, and it's especially for the caregiver, could be the mother or the father. I would not want to make that gender difference here, but it is intense. Of course, how each one would grieve would be different, but our entire team provides a lot of bereavement support for these children after the children pass away.
And I think that the best, I mean, how to say, the best ambassador for me about pediatric palliative care and is this teenager who died at the age of 14 of rare genetic illness. And he said that palliative care no longer means helping children die well. It means helping children and their families to live well, and then when the time is certain, to help them die gently. So Matti defined himself as a poet. I want to be remembered as a poet, a peacemaker, and a philosopher who played. And he really left a legacy. If you search on internet, you will see beautiful poems that he has written. And he really understood being tied to a ventilator during the last years of his life. But he's a very cheerful, smiling boy who really left a trace. And so that's something that I think many of you would be less familiar with, diversion therapy, knowing that I think in every pediatric office there are lots of toys and plays and games, but we can make really play a very, very active part of the treatment that we are providing. An unknown author said that recreation, leisure's purpose, is not to kill time, but to make time live, not to keep people occupied, but to keep them refreshed, not to offer an escape from life, but to provide a discovery of life. So as you know, children usually use 3 types of language: verbal, non-verbal, and play language. And that is what we use not only to understand what the child wants to tell us, but to also use it as a tool in the treatment, as a tool in their way of communication. So diversion therapies promote the involvement in leisure, in recreation and play by reducing barriers to patients' participation and provides opportunity where the individual may choose to participate. So in children, it is something very, very useful, as we said, but it's a new concept in India, even though it has been in use for the past 100 years. And I will just go through the case of a child, a teenager with Guillain-Barré syndrome, who was in ICU for 3 months, in and out because of his need of ventilatory support, being looked after in the hospital by his mother. He was the only child. And how we were able to use for this child a lot of diversion therapy during his stay in the ICU and subsequently using storybooks, drawing books whenever he became able to use a little bit his fingers, playing with another person or with his mother, and then using play also to do physiotherapy, body system and clown therapy. So that relationship that moved to a very personal relationship with the therapist, whether the therapist was the physiotherapist or the clown therapist or the music therapist. So you can see all these pictures that are in this presentation. We have the consent of the families to use them. So we can see also the follow-up. They are not in chronological order, because in the end, the photo in our room is once he has totally recovered. But so Anu will explain the type of physiotherapies that we are using and the benefits.
The different types of diversion therapies that we use. We use games. Could be any game, a game of chess, snakes and ladders, Jenga, anything. Puppets are also used. The child externalizes and uses the puppets to share what the child is feeling about his own feelings or emotions. Clay and sand activities are loved by children. We have also group activities where children sit together and they make uh, buildings or vehicles with Lego and such other games. There are also gentle exercises where we have toys where there is activity and there is movement of hand and there's movement of motor skills that they need to use. Arts and crafts are done. We have volunteers who come in to teach a group of children, some art, some craft, and they feel so happy despite cannulas in their hand to be able to actually sit there and make a craft. They make cards, so they're happy after they finish making the craft. Soap bubbles are something that works wonders with our children. Sometimes in a cannulation room, when the child is usually crying and wailing for that prick to be done, and then soap bubbles around and the cannulation is done as easily as possible. Our clown therapist, who roams around the entire hospital, spends time with all these children. So sometimes it's physiotherapy that she does, sometimes activity. So you look at, Karen, we have a small kitchen here where children cook for us. There are soups, there is tea, there is Maggie, there is biryani, everything happening around in our department. Painting. We have a child here on the extreme left below here who's waving a magic wand along with the clown therapist. There's some artwork that she's done, music. All these are things just help. Of course, the treatment is going to go on. The child is in the hospital. But if you look at the smile on the faces, it just tells you a lot more. What are the emotional benefits that we are noticing? The children are much more happy. They will ask, when can I come down to play? There is satisfaction of life, though they are in the hospital. Their morale is higher, they relax, their self-esteem, the concept of self is high. They have a sense of freedom. They're not just bound to that one bed with barriers around them. They feel independent. The autonomy that they would want, they're getting. There's a lot of self-confidence that they have. There are leadership skills. We have children sometimes who've come and ventured into our room. The next time we'll come with 2 more friends saying, okay, let's go and play there. There's a lot of tolerance and understanding because we're using play therapeutically. We're trying to see how much they understand about the disease, the illness, what are the challenges they're facing, what are the problems they're facing, what is it they're expecting. A lot of problem solving skills also happening using these diversion therapies. I can actually notice physical benefits of them. We see a decrease in the blood pressure, decrease in the heart rate, there is increase in bone mass. The GBS child that we were talking about was so happy to walk into the room and show us how he walks. There is an increase in lung capacity than compared to traditional just physiotherapy, just occupational therapy. Using all these diversional therapies, they are actually doing the physiotherapy, but they're enjoying doing it. There is a reduction in the incidence of diabetes. There is increase in muscle strength. So if the picture will tell you a lot of how these 2 children on wheelchair are doing different activities here. There is increase in the sense of well-being. Despite the limitations they're going through, there is increased in flexibility, balance, and coordination. there is an improvement in the immune system that can be noticed with the effects of all these. So to just wind up, ideally these activities that we call diversional activities, they promote self-esteem. It's also important for personal fulfillment and an emphasis on holistic care. So you come in, you're sick, and I give you medicines and you go out. It just doesn't follow that traditional way. That is providing physical, psychological, social, intellectual, spiritual, and cultural support for a child once he is in the hospital. It's like Plato said, you can learn more about a man in an hour of play than a lifetime of conversation. Our children playing with the dollhouse or in the kitchen or solving a puzzle tell us a lot more than we would sit across a table and a chair and ask them. Thank you very much for patiently listening to us. Thank you, Dr. Vero.
And we are now open to questions. I don't know who Anjali is going to guide us.
Yeah, so thank you, Dr. Veronique and Anuradha, for that absolutely wonderful presentation. I see one question in the chat box, and it's around adolescents who are admitted to hospital have overuse of mobile and social media. Unlike young kids who we give toys or coloring books to, what other measures can be taken? Because it sometimes strains their eyes, continuous screen time. Any other suggestions?
Yeah.
Both games. No, yes, Anu.
We see that a lot in our hospital too, which it's the easiest. So if a child is getting cracked and mobile, put his cartoon and he's sorted and we are sorted. We encourage children to read books. We encourage parents to read to children. We give toys to even adolescents and even to younger children, not just the younger ones, but even adolescents. We give games that would challenge their thinking, problem solving. So they love the Zenga. They love activity-based games. Allow the caregiver to. We encourage them to play with the children, and so of course books are being circulated around. We have a librarian, joint book librarian, who actually roams around with books and reads, and toys, coloring. There are so many of art we have in our room that these children have made in the hospital itself. So we discourage children to use a lot of mobile. We encourage mothers also to use this time to communicate and spend time with the children.
Thank you, Anuradha. Couple of other questions. There's a comment from Dr. Sushma Malik who says, remembering music therapy, playing the guitar, drums, and so on. Definitely. And often it's about engaging the entire family in making music. Yeah. Another question, I think, and this is a really practical one. Can soap bubbles be used in the PICU for a patient who's ventilator dependent? Dr. Vero?
Yes, why not? I don't know if we're thinking in terms of hygiene or whatever, but yes. Oh, my battery is running low. Sorry.
Yeah, thank you for that. Any more questions? Yeah, Dr. Sushma Malik again. Quizzes, board games, Scrabble, Sudoku.
Yes, and something that helps a lot is that we like the board games are very powerful. And when a team member, when a doctor takes time to sit down and play a board game, the parents play together, or we try to get peers together to play a board game, then that becomes much more interesting. And we can change their interest from the mobile to the board game.
Sure. Any more questions? Dr. Akshay Kamle, do you have a question? Okay. So I'm going to ask one if no one else has. Yeah. So I mean, in the Indian setting where the families are predominantly the decision makers, whether they're parents or extended family members. How would you advocate for an adolescent to have his or her voice heard around decisions that affect her care? Say, for example, you did talk about the child who refused to have a blood transfusion. And sometimes the parents might completely disagree with that. So how would you advocate for this adolescent to have autonomy?
So it would be very much helping both the parents and the child to see from their point of view what are the benefits and what are the burdens of a particular intervention. So that we try to match that and to see from the side of the adolescent, why does he make this particular decision? And from the side of the parents, because that can help us a lot to point out, to understand the maybe irrationality of a particular decision from the side, usually, I would say from the side of the parents, who we need to help them understand that being a good parent, they are very good parents and they want to do the best for their child. And that's what they are doing. And the fact of listening to the wishes of their child is actually the decision of a good parent. If Anu wants to add something to that.
Yeah, absolutely. We encourage communication between both. Sometimes we go midway saying, okay, if a child doesn't want, and let's have one more transfusion and then come back to the discussion. Most of the times we also share from our experiences how adolescents have an opinion of their own and how we could respect them. We've been able to come to a middle way and have these discussions with parents and adolescents together.
Any further questions? If not, I think we have almost finished on the dot. Do you take a psychologist's help? And
Very
Anuradha,
much.
do you wanna?
Yeah.
Anu-
Yeah.
Anuradha is a psychologist, counselor psychologist.
Psychologist, and yes, we do take our help. Even we take each other's help in the team here. But yes, of course, a perspective does help, because as a psychologist, I think we're a little more better equipped to be able to understand what the dynamics that are happening between the child and the parent, and then accordingly deal with the situation, rather than just have a let's our baat kare wala attitude. We say, okay, let's see what is happening here, and most of the times we are able to come to terms between the child and the parent to come to an agreement between both of them, and we are able to help both the parent, because we know at the bottom of it all, it's the care and the love that the parent has for this child that is ruling their decisions. So we respect that also, but we are here for advocating how we would love to also respect the individuality of an adolescent, despite, and not just because he's a patient and because he is young now, we don't respect his views. So sometimes advocating that through other experiences that we've had helps.
Right. So
Where would
Do
answer
some,
in a
Dr.
Hello?
government?
Prashant has a question, maybe?
yes, please, sir. I need to ask that whether do you make it like group therapy, similar age group people with similar disorders, so they can share their experiences, how to deal with them, the problems and solution. They might suggest themselves solutions. So anything like that you do there?
Absolutely. We do it with children with juvenile diabetes. We do it with children with CKD, children with cancer. But we concentrate the same type of cancer, meaning it's not the same to talk about leukemia or about bone cancer. So we do it as per needs and needs of particular children or teenagers. Nothing planned in advance. But when we see that children need it, or patients need it, or families, parents, fathers and mothers, yes. So it's a regular activity and very, very powerful, because a teenager or a child is very much helped by the queries, the questions, the doubts, the fears of peers, others who are expressing maybe their own fears, that they are not daring to express those, and they hear the answer to their fears or all the challenges that they are facing. So we do it with small groups, usually maybe 3 to 5, at times larger groups. Maybe we also do it with children with endocrinological disorders, children with CAH. You've had larger groups, Anu,
Yes.
maybe 10 to 15.
So all these different kind of,
Thank you.
so these support groups have been very helpful. We see how parents also share with each other. Children who are just newly diagnosed, the parents are very much worked up and stressed and anxious. The older parents say, you know, we too also went through this phase, and you know, we're now managing. And these support groups have really been helpful and powerful. We just need to be catalyst over there, and I think things get going between the group.
Thank you.
So I think we have one last question, and it's around, in government hospitals where human resources like psychologists and play therapists are missing, how do we go about with this lack of manpower?
One aspect would be learning ourselves how to use play therapy, how to develop skills of psychology. But I think if you work in a pediatric hospital or in a pediatric department, you need to insist to have at least one psychologist or one social worker who can get trained in using some of those techniques of play therapy, art-based therapy. I think.
Absolutely. And I'm wondering whether, volunteers could be invited into hospitals. So sometimes those are great resources to have.
Yeah.
Yeah. So we've gone over time. More than happy to take any more questions on the WhatsApp group. Don't forget to do your post test that's going to come with the YouTube link. And same time next week that's going to be our 8th session, and it's about antenatal and postnatal palliative care for neonates. So perinatal palliative care, and the faculty are going to be very distinguished neonatologists, so Dr. Sushma Malik and Dr. Ruchi Nanavati. Hope all of you can join then. Thank you so much for your time and your attention. Thank you, Dr. Veronica and Anuradha. Thank you.
Thank you, Manjari.
Thank you.
Bye. Thank you.
Bye, everyone.